Welcome to this explainer on crystal arthropathies. We're going to give you a clear, high-yield overview that's perfect for your clinical training. We'll break down the what, the why, and the how for these super common and, well, super painful conditions.
Okay, let's just dive right into a classic scenario. You're going to see this again and again. The acute monoarthritis. Now, your brain should immediately scream infection, and that's good because that's the can't miss diagnosis. But right behind it is a crystal arthropathy. So, how do we figure out what's really going on?
So here's our game plan. We're going to start with the king of crystal diseases, gout. We'll get into its backstory, then figure out how to diagnose and treat it. After that, we'll meet its great imitator, CPPD, also known as pseudo-gout. And we'll wrap it all up with a handy cheat sheet to lock in those key differences.
To really get a handle on gout, you have to start with the main character in the story, uric acid. Let's dig into the fundamental why behind this whole disease process. So here's the bottom line. Gout isn't just a sore joint. It's really a systemic metabolic disease. The root of the whole problem is having way too much uric acid floating around in your blood. We call that hyperuricemia. The painful arthritis, that's just the downstream effect of that core issue. You know, I love this slide because it just lays the whole process out so simply. It all starts with purines, the building blocks of DNA. Our body breaks them down into uric acid. Now, if you make too much uric acid, or, and this is the much more common scenario, your kidneys just can't get rid of it fast enough, the levels creep up, and bam, crystals start to form.
This number right here, this is the magic number you need to remember. Think of it like stirring sugar into iced tea. You can keep adding it and it dissolves until it doesn't. You've hit the saturation point. For uric acid in your blood, that point is 6.8. Anything higher than that, and you're officially in the crystal-forming danger zone.
Okay, this is a really critical slide because it busts a huge myth about gout. Everyone talks about the rich food and the alcohol, right? But for about 90% of people with gout, the real problem is that their kidneys are genetically programmed to not excrete enough uric acid. On top of that, things like chronic kidney disease and certain meds, especially diuretics, are huge drivers. The diet? It's more like throwing gas on a fire that's already burning.
And here it is, the textbook picture of a first gout attack. We call it podagra. It's no accident that over half of initial flares happen in the big toe. It's a cooler joint, being far from the body's core, and that lower temperature actually makes it easier for the crystals to precipitate out. Patients will tell you the pain is so bad that even the weight of a bedsheet is just agonizing.
So what's happening between these awful attacks? It's a huge mistake to think the disease is gone just because the patient feels fine. Nope. During these so-called intercritical periods, those nasty little crystals are still there, just hanging out in the joints, causing this constant simmering low-grade inflammation.
Wow, this comparison is just so powerful. On the left, you've got that red, angry, acutely inflamed joint from a single flare. But on the right, that's what happens after years of uncontrolled hyperuricemia. That's chronic tophaceous gout. Those lumps you see, they're called tophi. And they're literally solid masses of uric acid crystals that just destroy the joint and eat away at the bone.
All right, so we've got a good picture of what gout is and where it comes from. So now let's talk about the important stuff. How do we prove it? And more importantly, how do we treat it?
Look, a classic story of an exquisitely painful big toe is a pretty big clue. But the only way to be 100% sure is to do an arthrocentesis. You got to put a needle in that joint, pull out some of the synovial fluid, and look at it under a microscope. Seeing the crystals is the definitive diagnosis. Plus, it's absolutely crucial for ruling out a septic joint.
Okay, this is your classic boards question right here. Under a polarized light microscope, gout crystals are needle-shaped and negatively birefringent. A great little trick to remember this is that they look yellow when they're lying parallel to the axis of the polarizer. Keep that in mind because we're going to contrast it with pseudo-gout in just a bit.
When the disease has been around for a while, you can actually start to see the damage on an X-ray. Remember those tophi we talked about? Well, they can actually burrow into the bone, creating these classic punched-out erosions. You can see how they look like little scoops taken out of the bone, sometimes with a little overhanging edge. That's a sign of long-term undertreated disease. Now check this out. Ultrasound is an amazing, non-invasive tool that lets us see the crystals themselves. This double contour sign is super specific for gout.
What you're seeing is a bright white line of urate crystals literally caked on top of the cartilage, which creates the second line running parallel to the bone underneath. It's pretty cool. This right here is such a fundamental concept. You have to think about gout management in two separate buckets. First, you have the acute flare. Your job is to put out the fire with anti-inflammatories like NSAIDs, colchicine, or steroids. Then you have the long-term plan, which is preventing future fires. You do that by lowering the body's total uric acid level with something called urate-lowering therapy, or ULT. And that leads us to a really crucial point in modern gout care. We don't just treat the flares and then wait for the next one to hit. No way. We actively manage the underlying problem. It's a treat-to-target approach. The goal is to get that serum urate level below 6.0 and keep it there. Why? Because that allows the crystals that are already in the body to slowly dissolve over time. Okay, let's switch gears and talk about the other major player in the world of crystal arthritis. Calcium pyrophosphate deposition disease, or CPPD. Most people just call it pseudo-gout for a reason. It can look almost exactly like a gout attack. So if the buzzword for gout is tophi, the radiographic buzzword for CPPD is chondrocalcinosis. It's the classic calling card of the disease. You can literally see a fine, pencil-thin line of calcification running right through the cartilage itself, just like in this knee x-ray. You'll see this a lot, especially in older adults. Now, here's a key difference from gout. CPPD is kind of a chameleon. It can present in a bunch of different ways. Sometimes it's just an incidental finding on an x-ray with zero symptoms. Other times it causes an acute flare that perfectly mimics gout. And sometimes it can even cause a chronic, multi-joint arthritis that looks a whole lot like rheumatoid arthritis.
All right, let's pull all of this together now. We're going to wrap up with a head-to-head comparison and the absolute must-know points that'll guide you when you're seeing patients. This is it. This is your ultimate high-yield slide. If you're studying for an exam or getting ready for rounds, you need to burn this chart into your brain. Gout, negatively birefringent needles, loves the big toe. Pseudo-gout, positively birefringent rhomboids, classic in the knee or the wrist. Know this cold. So let's just hammer home these key practice points one last time. First, if you've got a hot, swollen joint, you really should be thinking about tapping it. Second, managing gout is a marathon, not a sprint. It's all about getting that urate level less than 6. Third, know your crystal shapes and colors. And finally, and this is so important, never forget that a patient can have both an infection and a crystal flare in the same joint at the same time. And we'll just end with this thought. As our population gets older and as we see rising rates of things like obesity and kidney disease, you are absolutely going to be seeing more and more of these crystal arthropathies. So mastering this topic isn't just about passing your exams, it's about being ready for your day-to-day practice. I really hope this explainer helped you get there.